Dr. Priti Kamdar. Ma'am is attached to Dr. Kamdar's eye clinic at Matunga, Mumbai. And I want you all to concentrate on the first line that it's a 100-year-old institute. And she's the joint secretary of the Maharashtra Ophthalmic Society, and she's the West Zonal member of the Glaucoma Society of India. Yeah, Dr. Tuli Pati, she's not 100 years. So, ma'am is going to talk about maximal medical therapy. Now, there's this school of thought that glaucoma is primarily a surgical disease. So, the role of medicines is questioned by some, and the role of MMT is questioned by many. So, ma'am is going to enlighten us on this subject.
Thank you for that very kind introduction. Good evening, everyone. It's heartening to see almost a full hall, where in most conferences you have empty halls. So I congratulate Ajanta Pharma for such a wonderful CME and Dr. Manish for inviting me here today. Medical management has remained the backbone of glaucoma treatment for a pretty long time. And if you follow the timeline of eye drops available to treat glaucoma, one would realize that there is a boom from 1995. And all these medications, with particularly the prostaglandin analogs, they brought down the rate of glaucoma surgeries worldwide. And the short-term safety and efficacy of eye drops and the limited and unpredictable surgical options which we had made us lean towards the concept of drops first. That's what we still follow, most of us. And then we had all these medications, but if you actually had to use all these individually, so we started talking about maximum practical therapy because of concerns of compliance and adherence to treatment. But then we have a very good pharma industry, and we have combinations, fixed drug combinations, which are not available in many parts of the world. And so it became very easy to give maximum medical therapy. So if you want to give, so in 2 bottles, we can give, and in 3 drops, we can give 4 medications. So it's become very easy to give maximum medical therapy. And if you want to add a 5th molecule, you can either choose netarsudil or ripasudil. So the practical therapy and maximum therapy are almost equivalent. So in a very systematic way, with minimal change in the lifestyle from the patient, we are able to give maximum medical therapy. So should we continue to do that? That is that's what we have to address. But we know nothing in life is free. So medical management also comes at a price. Not only does it cause ocular surface disease, but the higher the number and duration of AGM, more severe is the ocular surface disease. And then don't forget these horrible allergies, allergy to the molecule, allergy to the preservative, and plus the natural side effects of these eye drops, which sometimes make medical therapy difficult for patients. So, and then there is addition of a 3rd or a 4th anti-glaucoma medication effective? In the short term, yes. In a retrospective study, adding a 3rd or 4th drug to an existing regimen produced a clinically significant reduction in intraocular pressure in about half the patients. So about 50%, it's a big number. But when you count into the effect of the side effects, the allergies, and the ocular surface disease, the drug-specific adverse events, the efficacy goes down. So at 6 months, if you add a 3rd drop, the IOP drop was seen only in 27% and only 14% at the end of 1 year. So you may feel that when you're adding a 3rd or 4th drop, you're getting the IOP down, but that effect may be not sustained. And that's how now there's a concept of something called as interventional glaucoma. And I call it the glamorization of glaucoma. And this is the reason why many clinics feel that now I need a glaucoma specialist in my clinic. So we accepted the limitations of topical medications due to the lack of viable alternatives. But this is now no longer the case. Now, 3 such things which have good safety profile and are effective. So one is the SLT, which is available in India, sustained release drug delivery platform, which is still medical management, but without the side effects of the ocular surface or the allergies around the skin. and you have minimally invasive glaucoma surgeries, which are also done in India. Now let's take each of them. So SLT, I'm not going to talk in detail because there is a talk in the next session. But yes, 6 years of SLT, which was done, selective laser trabeculoplasty, done in patients with primary open angle glaucoma and ocular hypertension, 71% were drop free at the end of 6 years. So it's definitely something which you should offer as the primary treatment to patients who are ocular hypertensives or have early primary open angle glaucoma. Second is the sustained release delivery platforms, not available in India, but will come to India sometime or the other. The Durista has been there. It's around, you just drop this thing into the anterior chamber, and it slowly releases the drug, that is bimetoprost, for over 90 days. And the latest is the iDose TR. iDose TR, it releases travoprost over a period of 3 years. And if I just asked the guys at the American Academy that if you don't have insurance, how much does it cost? It costs 14,000 US dollars. So if it is going to be effective, it will become cheaper, it will come to India. So they will experiment, they will find out the side effects, and then we will use it. We'll be wiser when we use it when it comes to India. So MIGS. MIGS usually piggybacks on cataract surgery. So whatever GAT, iStent, Zen, Trabectom Bank, all these are done in India, but not in isolation. So if you have a patient who has primary open angle glaucoma and has a cataract, maybe you will not go MMT. You will advise cataract surgery along with one of these procedures. There are certain reports where GAT was done in isolation and with good results. So this is one thing that, yes, we don't always go MMT. What about incisional surgery? Now, this is something which was published in 2024, July, in Ophthalmology, where 227 patients underwent trabeculectomy with advanced glaucoma, and 226 patients underwent medical therapy like how we do in escalation. And they were followed up for 5 years, and they found that primary trabeculectomy is more effective in lowering IOP and preventing disease progression at the end of 5 years with a similar safety profile. So this is what the recent evidence says. So what? Yes. So if it comes to SLT, MIGS, I don't go full MMT. But what happens when you have to do a trabeculectomy? Incisional treatment versus medical management. Do you still go MMT? So in one-eyed patients who have advanced glaucoma, who have a longer life expectancy, one-eyed patients are, though you have to balance how fast they are progressing vis-a-vis and their mental makeup. So, but in advanced glaucoma, when a person has a longer life expectancy, I would definitely go in favor of incisional treatment because they want their eyesight to last for a longer time. Surgical complications in the other eye is what makes a patient reticent, and so most of the times the patient drives the decision. There are some conditions where the pressures are very uncontrolled when you put your foot down. But whenever the patients, they ask me, particularly one-eyed patients, that doctor, will I lose my eyesight after the glaucoma surgery? Utna to rahega na. So is anyone in a position to say कि हाँ उतना तो रहेगा? No. What we are telling them is, अगर operation अभी नहीं करेंगे, so you will lose whatever you have. You're not telling them with confidence that yes, you will maintain vision at the end of surgery, and that's why it becomes unacceptable to patients who are one-eyed. They're more scared. But however, if they are not controlled, then you should, and they have a longer life expectancy, you should lean in favor of incisional therapy and start the conversation early. So to summarize, SLT should be offered to each and every patient who has primary open angle glaucoma, is ocular hypertensive, I would say early POAG, with pressures between say 20 to 30-35. FDZs have made maximum medical therapy very easy, and adding a third or fourth drop can be effective in the short term. but side effects increase. And when you're adding the third or the fourth drop, start the conversation on surgery. They may not agree immediately, but when over a period of 6 months to a year, if the pressures, particularly the pressures, are borderline, they start the conversation on surgery early. For me, I have started recommending SLT to the patients, which I told you, but the main limiting factor is the scare. Acha, laser karenge, so what they say is, let us start medicines for 6 months, let us try, and then we'll think about SLT. But I feel it's time to change our mental makeup and use SLT, and of course MIGS is there. So thank you for a very patient listening, and thank you once again.
Thank you so much, ma'am. That was an excellent talk. Uh, so, a quick question to the panel. We have limited experience with. No, they will come up for the next session. So, our limited experience with SLT. So, quick comments from anybody in the panel regarding the role of SLT in Indian eyes.
Anything on a virgin eye works the best. So it's, if it is SLT, it will work the best. If it is a medicine, it will work best. If it is primary trabeculectomy, that also works the best. So first of all, what we have to do is how much the patient needs. What is the status of the patient? There are so many things, but we should go always stepwise. Now the SLT is coming up like in Indian, there are a lot of studies in Indian eyes, it is working the best. So there's no harm of trying the SLT to avoid the side effects of the medications. So as long as it reaches the target IOP and the patient is stabilized, fine, then you start one at a time. Like one medication which works best for the patient. And always keep it in mind that the second medication will not work the same way the first medication. So it is not like that unitary method. So one medicine is 20% drop, second medicine is 40% drop. So it doesn't work that way. So with that idea, we have to keep adding, and whenever this additional medication works, then you combine it with FDC. That is the way one should go. And one should not keep the trabeculectomy reserved for later in the future. So whenever you feel like this patient is actually a patient who will work the best in trabeculectomy, go for primary trabeculectomy. After reducing the intraocular pressure to some extent, go for primary trabs. That gives you the best result.
Dr. Priti, it was very clear from your talk that you have an SLT.
Mumbai, we have a rotating SLT.
You have?
It is on demand.
Or let me say you have access to a SLT.
Yes, I have access.
So I can tell you where I come from in Delhi, hardly one or two general ophthalmologists have an SLT. None of the known glaucoma people have an SLT. Okay. So the availability of SLT, and let me ask, we are in Kolkata. I think I am aware of only 2 centers in Kolkata who have SLT, and I think Kolkata has the maximum number of GSI members now. So look at this. So I think the availability of SLT is an issue. What Arun is going to say, I'm not spoiling his honeymoon, but in Delhi, Kolkata, major metros, the availability is an issue. So what I suggest is that we do still the photocoagulation laser trabeculoplasty. I think the results have been pretty much equivocal. We have access to the retina laser, and we can do a trabeculoplasty with that. However, I am in favor of, for advanced glaucomas, one-eyed patients, I am in favor of doing a trap. That is what my message is.
Yeah, I think SLT is for ocular hypertensives, best it works, and early POG, as I said, if the IOP is between say 25 to 35.
But we get
if
very
it is above 40, 45, you're not going to get the pressure down with just SLT.
But most of us tend to see more advanced glaucomas. That is the problem with India.
I think while counseling patient, we should always remember what is the efficacy of it. We should not go by that light trial which says 100% success rate. Nothing in life is 100%, that we must remember. So counseling is extremely important, and it works well in the treatment naive patients. Early glaucoma and ocular hypertension and treatment naive patients.
SLT seems to be like the phoenix. It's again rising from the ashes, because when I was a fellow, it made waves. Then it just went away, and now it's again making a comeback. Regarding Durista, it's recently received the FDA approval. So would the panel be happy with introducing an intracameral implant?
See, Durista, it's not available at this point of time in India. it is approved by FDA, but only for single use. That is up to 3 months, and the extrusion rate is 30%. So what will happen to the patient after 3 months, and we don't know in between if it is expelled out, and whether that intraocular pressure control is consistent or not. So all these things we need to keep in mind.
Also everything, Arjit, everything that FDA approves.
You're correct.
India may cost and this thing. Many MIGS, she coded Trebectome. It's already gone. So it came and went. And I'm telling you, in 3 years' time, when we reassemble in Kolkata, you will see many of the MIGS would have gone. Just that what Rajul is going to present is going to be the practical scenario. What he's going to say is going to be useful for India. But there are many in Delhi who are doing for advanced glaucoma just to reduce 1 or 2 drops, which I am a little ginger about.
Or where we don't have any other option, we have done. In fact, what Dr. Rajul is going to present that data, we started mix in advanced patients where we did not have any option. Short of TSCPC, we did that procedure. So whatever months that we can give, that vision we can give to the patient, we can take that mix there as our advantage.
And like ma'am mentioned, Durist has been approved. Initially, it was approved for multiple doses. Now it's been reduced to a single dose because the cornea is getting decompensated if you kind of reintroduce it. So there's this issue. I mean, it's not 100% foolproof procedure. And ma'am, you kind of presented MIGS as Betal, or was it?
It is piggy banking. Right now, it's not used in isolation.
Betal on the Vikram. So I think thank you so much, madam. We'll move to the next session. It was a very interactive session.